Hi, I'm Tyrone. You want to book on your booking on here? Feel free to call me direct at 303-4080 for all your
All right. Good morning, everyone. My name is Dr. James Thomas. I am a faculty member in the Bethune College of Public Health, and I'm also Tyrone Bethune's dissertation chair. First and foremost, we'd like to welcome and thank you all for joining in and attending his dissertation defense. Tyrone has been working very hard to get this defense done, and it's an honor and a privilege to be able to see him present his research and his work. Before we get started, I like to ask everybody if you can, whenever you're joining in, or um, if you have noticed your audio button has been unmuted, I like to ask you to mute yourself. During Tyrone's defense, we also like to ask you all to turn off your cameras to try to minimize any distractions. There will be a period at the end for you all to give comments or ask any questions. And we, the way the format or the layout, we will ask Tyrone to present for about 45 minutes. And at the end of the 45 minutes, we will allow everyone to mute themselves and turn on the cameras to give any comments, to ask any questions. And after his question and answer
Mm-hmm.
period, we will ask everyone to sign off of Zoom where we can meet with Tyrone. And without further ado, we're going to allow Tyrone to present his dissertation, Money, Power, Respect, African American Men Navigating the Complexities of Healthcare Across Rural North Carolina. So without further ado, I'd like to turn it over to Tyrone at this time.
Thanks, Dr. Thomas. And I just wanted to make sure that you all can see my screen. And I know that folks are still trickling in. And so if you would, Dr. Thomas, could you allow folks and admit folks that are in the waiting room?
Yes.
Thank you. I'm muted. Sorry. Good morning, everyone. My name is Tyrone Bethune, a doctoral student in the John Ping Sue College of Public Health at Georgia Southern University. It is indeed my pleasure to bring this audience, the community, the committee together to present and defend my dissertation titled Money, Power, Respect, African American Men Navigating the Complexities of Healthcare Across Rural North Carolina. Here are a few of the items that I will cover during our time together. Introducing my committee, setting the stage to really ground us in the conversation. You'll hear some of the findings in the literature, the methodology, the analysis, and I'll end with some acknowledgments.
Tyrone, briefly, could you share your screen again? We're not able to see your slides.
Give me 1 second. And can you see them now, Dr. Thomas?
Yes, we can see them. Thank you.
Okay, good, good. Sorry about that. Just wanted to pause and acknowledge my committee members, Dr. James Thomas, who served as my chair, Dr. Betty Appentang, Dr. William Mays, and Dr. Stacy Smallwood. I'm extremely passionate about this work, so I think it's important for me to stop and frame and make space so that I can set the stage for the conversation. And I'll pick up around the year of 1526. Won't spend too much time on the diaspora, but I think it's important to recognize what it is, what it was, and what it will forever be. I would be remiss if I didn't pay homage to the motherland. And so 1526 until around 1619, the arrival of the first captives to the Jamestown colony in 1619, often seen as the beginning of slavery, but records show enslaved Africans arriving in North America as early as the 1500s, moving up to June 19th, 1865, where Union troops freed enslaved African Americans in Galveston Bay across Texas, roughly 2.5 years after President Abraham Lincoln signed the Emancipation Proclamation. Moving up to 1932, 1972, the end of Jim Crow, this idea of separate but equal, we saw the Tuskegee experiment, Henrietta Lacks, and the rise and rest of Dr. Martin Luther King Jr. Moving up to 2010, which I believe it is an important year as we think about health policy and what the passage of the Affordable Care Act, or Obamacare, and what that meant for healthcare coverage, access, and 2020. 2020 was a rough year as it relates to Black men's health, their safety, but also a very illuminating year, if you will. We saw racism declared as a public health issue. We saw more funding around health equity. However, even that momentum around health equity created disparities among those who do the work. And we coined this topic as health equity tourism, which I will touch on later in the presentation. There are no start and stops to this timeline because we are forever learning the historical knowledge, and the story continues to unfold, which gives me hope about the future of Black men's health. The information you see here, what you hear here is informed by scientific evidence. The problem: African American men experience disproportionate health outcomes and chronic diseases such as diabetes, hypertension, obesity, asthma, and stroke when compared to their white counterparts. For perspective, Black men only make up approximately 12.4% of the total United States population. However, this community is disproportionately burdened by cardiovascular diseases, despite the efforts made by the government to improve health equity. Here is a peek at the literature. Let's start with the military. Lee explored the socioeconomic differences in the health of Black Union Army soldiers. And this study is unique because most of the work carried out to examine the socioeconomic differences in health status among the U.S. slave population really lacks clarity regarding the pattern of diseases, cause-specific mortality, and the timing of deaths. Lee's findings suggest that men who were formerly engaged in elite occupations were much less likely to die from the disease compared to those in farming occupations. Although African American soldiers were drafted into the army, they were discriminated against. African American recruits were not allowed to be promoted as commissioned officers, thus being paid less than white soldiers. And so here I'm just illuminating the disparities in care, the disparities in treatment, and even in career progression. Historical context. Although Jim Crow laws were outlawed in 1964, many of the health impacts continue to perpetuate African American men with lived experiences under its ruling. Krieger and colleagues primarily focus on the U.S. rates of premature mortality, and this is death before the age of 65, to really yield some novel evidence. And their findings suggest that when stratified by race in Jim Crow polity, there are clear disparities in mortality among African Americans and Caucasian individuals. Their empirical findings offer evidence that the elimination of legal racial discrimination had beneficial mortality effects for the African American population. When we think about trust in healthcare, we often think about Henrietta Lacks, the Tuskegee syphilis study. And so in 1932 until 1972, 600 men in Macon, Alabama were unknowingly a part of an unethical experiment. The study was conducted by the federal government to examine the effects of untreated syphilis. The researchers told the Black men they were being treated for bad blood and promised them free medical care. 400 participants received improper treatment for the disease they contracted, even when penicillin became the recommended treatment in the 1940s. The next two slides will outline more of the epidemiological trends in the United States. The Health and Human Service Office of Minority Health reports that from 2014 to 2018, African American men were 1.2 to 1.5 times more likely to have new diagnoses of colon and prostate cancer when compared to non-Hispanic white men. 2.5 more times likely to die from stomach cancer, 2 times more likely to die from prostate cancer than non-Hispanic Caucasian men, 60% more likely to have liver and inflammatory bowel disease, cancers, and to die from the disease. The statistics here represent the work of the researchers at Northwestern who conducted a study to understand this phenomenon regarding heart disease in the African American population. Their findings suggest that African American men had a 1.6 times higher risk for developing cardiovascular diseases when compared to Caucasian men. The study found that clinical factors, socioeconomic factors, and lifestyle behaviors are the greatest attributes of higher risks for African American men. This unique finding is an important caveat to minority health research because it rebuts that there is this unexplained or just this genetic speculation that African Americans have higher risk. The work here reminds public health practitioners that disparities could be prevented by addressing social determinants of health. COVID-19, the COVID-19 pandemic highlighted deep racial and gender disparities with African American men being among the most who were disproportionately affected. Surveillance data significantly revealed that significantly rates of higher rates of COVID mortality in Black communities. A Kaiser Family Foundation study found that in Wisconsin, African Americans only made up about 6.3% of the population. However, they accounted for 20.5% of COVID-19 deaths, dying at a 3.3 times higher rate of the state rate. While similar data wasn't available for North Carolina, this study really does open the door for other states to use rural data to drive more equity-focused action. Here's a snapshot from the North Carolina Health Equity Report. Health outcomes vary by racial and ethnic groups in North Carolina. Racial disparities are experienced from the womb to the tomb, as African American women experience disproportionate prenatal health outcomes. African American babies are more than twice as likely to die during childbirth when compared to white and Hispanic subpopulations in North Carolina. In addition, African American women are 3 times more likely to die from childbirth than Caucasian women. Length of life and quality of life are worse for African Americans in North Carolina. Healthy North Carolina 2030 Task Force reports health outcomes are worse for nearly every indicator among historically marginalized groups, particularly African American residents. And so you may be thinking, why am I pulling out these stats of maternal child health and women? And it's simply because not too many people, not too many organizations, or researchers are extrapolating data to prioritize Black men's health, particularly in North Carolina, particularly that rural framing, and that rural framing in North Carolina continues to add that layer of granularity. The FDA defines rural health as the health of people living farther away from care and essential services. Nearly 1 in 5 Americans live in rural areas where residents tend to be older and face greater health risks. Healthcare in these communities is often less accessible and delivered differently, with only 10% of primary care providers serving rural areas and 5% of rural counties lacking a family physician. For example, just to put this into perspective, while early detection can reduce prostate cancer deaths, yet in Edgecombe County in North Carolina, the mortality rate is 41.9%, nearly double the state average. With with researchers reporting low-income African American men being the most impacted. And I grew really interested when I came across studies like these that help capture some of these regional and rural statistics. However, there is still a need for more. There are still questions that need to be answered. And so all the information that you heard leads me here. Here was the purpose of what I aim to do. At a high level, this research intends to shed light on African American men's health. But to put this more granularly, I aim to, one, explore how social determinants influence the health experiences of African American men in rural North Carolina. Two, to examine the perceived effects of racism. Three, to identify the barriers that hinder health maintenance among African American men in rural North Carolina. Four, to investigate the coping strategies, resilience factors, and support systems that African American men use to maintain their health despite systemic and personal challenges. Frameworks and models. Here are some of the prior models and the thinking that influenced the culmination of my work and the conceptualization of the material included in this presentation and my document. And so let's start with weathering. The weathering framework suggests that chronic stress from discrimination, economic hardship, and environmental hazards accelerates biological aging and increases disease risk. Prolonged activation of stress systems, this hypothalamic pituitary adrenal axis, the sympathetic nervous system, this elevates cortisol and adrenaline, these hormones, leading to inflammation, oxidative stress, and metabolic dysfunction, overall contributing to this aging and this sped up aging process and chronic illness in African Americans. Allostatic load. Allostatic load refers to the body's cumulative wear and tear from chronic stress and repeated activation of stress responses. Persistent stress disrupts homeostasis, this internal balance, leading to harmful effects like dysregulated cortisol, high blood pressure, inflammation, and metabolic dysfunction. It helps explain health disparities by linking prolonged social adversity to physiological damage, highlighting the need for systemic interventions. John Henryism hypothesis. Perpetual health disparities affecting African American men in the United States have influenced extensive research into the psychosocial and behavioral adaptations of stress among this particular population. In 1983, Dr. Sherman James, who is now faculty at Duke University, developed a conceptual model to examine this phenomenon. James's framework looks at coping and stress and explores in more detail how the two can adversely affect health, particularly in the context of socioeconomic disadvantage and systematic racism. Historically, the John Henryism hypothesis derives from African folklore of John Henry, a steel driving enslaved man who worked tirelessly to compete against steel powered machinery, which ultimately led to exhaustion. The hypothesis suggests that individuals who experience significant psychosocial and physical effort to overcome socioeconomic challenges and systematic inequities are at an increased risk for adverse health outcomes. Racism as a public health issue, and this definition comes from Dr. Kamara Jones, faculty at and professor in the Rollins School of Public Health at Emory University. And Dr. Jones shared that racism negatively impacts an individual's physical and mental health, thus preventing them from attaining the optimal level of health and consequently impacting the health of America. A growing body of evidence of scientific literature shows over 400 years of racism in the nation, which has had detrimental impacts on Black and Indigenous people of color. Ignited by the health disparities illuminated in the COVID-19 pandemic, the declaration of public health as a public health concern, and the murder of George Floyd, health equity research has become a new interest, according to Lett and colleagues. Dr. Lett defines this phenomenon as health equity tourism, the practice of investigators without prior experience or commitment to health equity research really parachuting into the field in response to timely and often temporary increases in public interest and resources. And these scholars report that these tourists infiltrate the equity space because they recognize the fiscal return rather than approaching this research to build sustainable commitment to health equity work. On April 8th, 2020, the CDC, the nation's leading public health agency, declared racism as a public health threat and began taking specific action to address the concerns. The public health workforce is not exempt from changing and reframing our thinking from these said experiences. And so since 1994, the 10 essential public health services have guided public health advancements. However, researchers began to understand that to make population level achievements, this framework needed an update. And so, released on September 9th, 2020, during the COVID-19 pandemic, the public health community received an updated iteration of the framework to reflect the ever-changing healthcare landscape that has dramatically shifted since its inception in 1994. And so on the left, you see the former, and on the right, you see the updated framework with health equity as the nucleus. Social determinants of health, they are defined as the conditions in which people are born, grow, work, live, age, and the wider set of forces and systems that shape the conditions of daily life. In recent years, the social determinants of health framework have received considerable attention from scholars using the concept as a fundamental approach in the fields of population and public health. And while there is substantial scholarship around recognizing social determinants of health as a critical issue in public health, thinking about education, healthcare access, economic stability, social environment, built environment, there are still gaps in research relating to African American men. And so that leads to the methodology of my work. This research is qualitatively designed Qualitative research explores the meaning behind experiences and creates space for awareness and purposeful action. In public health, it helps us understand health behaviors, uncover lived experiences, and inform theories, needs assessments, and intervention design. A phenomenological approach was used to explore the lived experiences and cultural perspectives of African American men in rural North Carolina. This particular method is useful for capturing the meaning behind the participants' experience. This study used a semi-structured interview approach to gather rich information, in-depth data that wouldn't be captured through quantitative design methods. The format allowed for flexible follow-up questions and offered insight into participants' nonverbal cues and spontaneous responses. Here are my 4 research questions. 1, in what ways do African American men in rural North Carolina perceive that social determinants impact their health? 2, in what ways do African American men in rural North Carolina perceive how racism impacts their healthcare experiences? 3, what obstacles experienced by African American men in rural North Carolina hamper health maintenance? 4, how do African American men in rural North Carolina cope and remain resilient while navigating their health maintenance? And so here's a snapshot of my instrumentation matched with the research question. And these questions derive from the social determinants of health framework, weathering, allostatic load, and the conceptualization of the John Henryism hypothesis. This study used a dual sampling approach, purposive and snowballing sampling to recruit African American men in rural North Carolina. I began targeting trusted networks, including HBCU alumni, members of the Panhellenic Council, Prince Hall Lodges, 100 Black Men of America, and historically Black churches. And to support this effort, I enlisted recruitment champions to help me across my networks and across the state to help connect me to these groups and to ultimately reach the intended audience. There was an incentive for participation, and to expand that reach, participants were encouraged to refer others who met the inclusion criteria. Additionally, there were social media campaigns across Facebook, Instagram, LinkedIn to support the outreach efforts. Eligible participants, they self-identified as African American men, age 27 to 75, lived or currently live in rural North Carolina, and have been seen by a healthcare provider in the last 4 years. And to justify these delimitations, I'll share that in order to capture the viewpoints of African American men at all points of all periods of life, from early adulthood to senior years, the chosen age range was necessary. The higher restriction 75 was intended to cover older adults who might have experienced long-term systematic hurdles and health inequities, while the lower limit 27 was chosen to concentrate on people who have had enough life experience navigating healthcare systems, limiting the criteria to those who have fairly recent experience with with the healthcare system, and this allowed me to eliminate the recall bias. Some data collection. Here are some of the key points to call out for data collection and the steps needed to ensure the work was carried out both in compliance and that the research protocols and ethical standards were met the needs of IRB. I utilized Zoom. Zoom had an intuitive system that was helpful with the transcription element. Signed consent forms were obtained from each participant before scheduling interviews and also read aloud before the ascertainment process. The study was approved by Georgia Southern Institutional Review Board during the fall-ish semester of 2024. Informed consent forms were signed, and they outlined the study procedures, participants' rights, and the purpose. All right, so data analysis. The process. Atlas CI is a powerful qualitative data analysis tool, and this software that helped me organize code and analyze qualitative data. It was very user-friendly, flexible coding system that allowed me to easily edit and adjust my codes, collaboration and cloud integration. And this was important as I needed a second coder to address the trustworthy piece that I will mention momentarily. And on the right, you will see a snapshot of the code book. And this was a very iterative process to track my analytic decisions. And so you probably can't read it, but I just wanted to show you that that was a very extensive document that showed all of the codes, all of the themes, and some of the ways that I memoed. Data analysis, the thematic analysis. Clark and Braun's thematic analysis framework guided my approach to identifying and analyzing and reporting patterns within the data. I began by familiarizing myself with the transcripts, spending time reading and reflecting to make sense of the participants' experience. Throughout the process, I used Atlas TI for my coding, memoing, and documenting my thoughts, questions, and insights to support the trustworthiness of the study. Generating codes helped me label key concepts and allow me to begin organizing the data and be able to conceptualize the data. As I moved through the coding, themes naturally emerged, representing meaningful patterns in the participants' narratives. Then I reviewed and refined the themes to ensure that they aligned with the data and clearly told the story of the findings. And finally, I wrote a detailed analysis of each theme, weaving together data abstracts and a narrative interpretation to present the insights that you'll hear today. In qualitative research, establishing rigor and validity is essential. Lincoln and Guba outlined four key criteria for trustworthiness: credibility, transferability, dependability, and confirmability. As a researcher, I recognize that my own experiences and perspectives can influence the process. And so just thinking back to the cultural competency course that I took by Dr. Smallwood, thinking about that social identity will reminded me of of that importance, and acknowledging that even with my similarities to the community, I needed to avoid um, any assumptions of this monolith. And so credibility, highlighting the accuracy and truthfulness of the findings, thinking about the data saturation, in which I will touch on momentarily, transferability, designing the study in a fashion so that the process could be applied in other settings and potentially across different populations. To strengthen dependability, I brought in a second coder to reduce potential bias. While I had a prior experience using in vivo, in my previous work and in research for this study, I used Atlas TI, which allowed me to assess intercoder reliability using the Krippendorf's alpha. A score of 8.22 was achieved, above the standard threshold, indicating strong agreement and reinforcing the credibility and reliability of the findings. Confirmability, thinking through the ways to remove biases and personal assumptions. And I share all of this to emphasize that the themes and the findings that you'll hear are grounded in a rigorous, reflective, and trustworthy analysis of the participants' voices. All right, and so my findings. The study included 10 participants ranging in age from 30 to 73 years old, with a diverse representation of rural counties in North Carolina. Participants span across education, government, entrepreneurship, plant processing. Educational backgrounds varies, as you see, with most participants having some level of higher education. Marital status was split. Regarding parental status, 4 participants were identified as fathers. Health outcomes varied among the group, including mental health concerns such as anxiety, depression, physical conditions like obesity, carpal tunnel syndrome, high blood pressure, diabetes, kidney disease, and prediabetes. Notably, 3 participants reported no current health issues. During my perspectives, we were imagining about 18 participants. However, data saturation was reached earlier than planned, with no new themes emerging after the 7th interview. This diverse group provided a broad spectrum of perspectives of voices and experiences, contributing to a well-rounded understanding of the study's focus. All right, and so here are my themes: socioeconomic and systematic barriers, financial constraints, thinking about geographic limitations and transportation difficulties that significantly hindered healthcare access for from African-American men in rural North Carolina. Thinking about cultural stigmas, that really came up, a strong stigma around discussing health, particularly mental health, in the Black male community. Theme 3, cultural competency and relatability. Participants emphasize that culturally competent providers, especially Black male providers, foster trust and improve healthcare experiences, while dismissive or insensitive care really leads to alienation in care. Preventative care, participants recognize the importance of regular checkups, Challenges in mental health. Participants frequently experience emotional distress due to systematic barriers and societal expectations, often leading to emotional suppression and unaddressed anxiety. Theme 6, stress management. Participants use adaptive coping strategies like exercise, spirituality, peer support, but some engage in maladaptive behaviors like smoking to manage stress. Awareness and education. Many participants grew up with limited education, contributing to poor long-term health behaviors. Um, I'll leave it there. And accountability network. Support from family and peers played a key role in maintaining health with open discussions in families around improving that motivation and accountability. This table is included in my document, but I just wanted to share a visual to represent what that thematic analysis process looked like. And I have each of these mapped out through to the theme, their quotes, and their rationale. And so thinking about cultural stigma, some of the things that came up when I told my mom I was going to therapy, she asked if I was okay, if I was thinking of hurting myself. That was from participant one. And this really underlines the pervasive um, cultural stigmas around mental health in the Black community. And here it is again, just matching that to the rest of the themes. And again, I won't spend too much time on these next 4 slides, but I did want to give the audience a peek at the visuals of the analytic process of each research question. And so thinking about research question one, African-American men in rural North Carolina highlight several ways in which social determinants influence their health. And those determinants were economic stability, neighborhood and built environment, education access and quality, social and community context. And so I'll do this for each research questions, but I won't spend too much time on that because I want to discuss that in a moment. So you'll see that for research question two, I'm just looking at the analytic process of the mechanisms that how racism impacts their healthcare experience. Same here about the obstacles that that hinder their ability to maintain healthy behaviors. Sorry. And here are some strategies for resilience. And so discussion. Just wanted to pause here and, just dig a little deeper on each research question. Discussing research question one, in what ways did African-American men in rural North Carolina perceive that social determinants impact their health? African-American men in rural North Carolina perceived social determinants such as economic stability, education, neighborhood conditions, and social support as major influences on their health. Consistent with the literature, the study found that limited job opportunities and financial instability hinder access to care, even for those with insurance. Rural settings worsen these barriers due to long travel distances and poor public transportation. Many participants lacked health education across the lifespan, impacting health behaviors around nutrition and prevention, echoing the findings by researchers identified in the literature review. And despite these challenges, participants highlighted the value of peer and familial support in promoting health, supporting the work of Du Bois, um, and thinking about that role of community health and advancing health equity. Research question two. In what ways do African American men in rural North Carolina perceive how racism impacts their healthcare experiences? Participants identified systemic racism as a major barrier to equitable healthcare. Many describe healthcare experiences with many describe experiences with implicit bias, feeling dismissed or stereotyped by providers, leading to mistrust and avoidance of care. These findings align with Powell and others who note that bias undermines engagement with the healthcare systems. Structural racism was also evident in rural areas with limited healthcare access, disproportionately impacting Black communities. A lack of provider representation, hiding feelings of alienation and misunderstanding. Participants linked these experiences to chronic stress, reinforcing the weathering framework and its connection to the conditions like hypertension and mental health challenges. Research question three. What obstacles experienced by African American men in rural North Carolina hamper health maintenance? And so, thinking about the findings revealed that African American men in rural North Carolina face multiple barriers to maintaining their health, including transportation issues, financial constraints, cultural stigmas, long distance traveling, and a lack of nearby providers, often delayed care. Financial instability further limits access to healthy food, gyms, and specialized care. Cultural stigma around mental health also discourage open this idea of open dialogue and therapy, while the strain of juggling family and personal responsibilities often lead to African American men neglecting preventative care. And research question 4: how do African American men in rural North Carolina remain resilient and cope while maintaining their while navigating their health maintenance? Despite significant health challenges, African American men um, in rural North Carolina use various coping strategies to protect their health. Participants drew strength from faith and spirituality, often relying on prayer during difficult times. Physical activity really came up as a theme. Participants really look forward to using that to manage their stress alongside support from family and peers for encouragement and accountability. Some also relocated to less stressful environments like a rural environment. Just for their sanity, or sought culturally competent providers, and really look for traveling, and relied on their cars and their transportation to reach their urban providers. And all of this really highlights the high effort coping strategies that align with the John Henryism hypothesis, highlighting the determination to overcome personal and systemic barriers to health. Making the case, this slide really aligns the research findings with the core constructs in the dissertation title, showcasing how the themes of money, power, respect, and healthcare navigation shape the lived experiences of African American men in rural North Carolina. And so, thinking about money, economic barriers to healthcare, power, systematic and systemic inequities in healthcare, respect, cultural competence and relatability, and the navigating complexities of healthcare piece, thinking about the challenges, the barriers, the coping, the resilience. And so just wanted to pause and make space for, why I chose the title and how it aligns with the research findings. All right. And so here are some of my recommendations. My recommendations are to encourage mental health support, to think about representation in healthcare. And this really reigns supreme for me. I was a person who have been a part of a lot of diversity programs. And so promoting diversity in medical education through scholarships, mentorship, and HBCU programs, partnering with historically Black male organizations, and integrating that cultural competency piece in medical education, addressing accessibility, enhancing preventative care, and those initiatives. And so thinking about early education in schools, offering low fitness programs. Some more recommendations. This is around reducing stigma, uh, particularly around health discussions. And so launching tailored health campaigns, engaging the faith-based community, and training community leaders as health ambassadors. To promote health literacy across the lifespan, to fund school programs, provide community workshops on nutrition and disease prevention, and to foster accountability networks, encouraging this family-based wellness, um, thinking about wives, mothers. And so sometimes if we can't reach Black men, maybe we go through their wives, maybe we go through their mothers. And so thinking about women-led organizations and establishing peer mentorship initiatives and promoting this idea of group participation in health screenings and medical visits. While this study offers valuable insights, and it is important to pause and acknowledge the importance and recognize the limitation and gaps, the findings are specific to African American men in rural North Carolina, so they may not generalize to urban or suburban population. The sample was mostly middle-aged, limiting the perspectives from younger or older men. The absence of female perspectives, such as those of wives and mothers, limiting the understanding of their role in men's health. Chronic stress was mentioned, um, but it didn't really explore in depth as a health determinant. This cross-sectional design captures health from a specific viewpoint and not across time, limiting how health behaviors change over time. And so the study focused on individual experiences without emphasizing policy level solutions, and didn't really fully address the intersectional factors like religion and culture. Finally, the healthcare providers' perspectives were not included in this study, which could have added more depth to the understanding of patient-provider dynamics. And so here are my contributions to public health. This is my contribution to science, my contribution to the knowledge base. Many studies, many researchers, and leaders who do not look like me often speak about this community and Black men from a negative point of view. However, I hope that my work is a launching pad for, really reframing and changing that narrative. And I hope that really helps me in my career. And so moving from exploitation to empowerment, addressing health disparities in African American men, advancing the understanding of social determinants of health, unpacking the role of racism and health outcomes. Hopefully, this will encourage more policy and programmatic recommendations. Um, I think this research will really fill a gap as it relates to rural health research, policy reform, clinical research, and making sure that we are able to capture and recruit Black male participants, thinking about community health research and models, and lastly, resilience and coping mechanisms around health maintenance. And I say all of this because if the only time we are cheering on African American men, if the only time we do that when they're wearing our favorite team's jersey, we are wrong. And so just wanted to move from exploitation to empowerment. Here are my plans for dissemination, and that is through participant engagement, through the media, through the academic community, partnerships, and resource development. All right. And last, I wanted to leave with some acknowledgments. God has been really good to me. And so I owe the biggest shout out to the United Negro College Fund and to the Gates Millennium Scholarship Program for funding all of my degrees from my bachelor's, my master's, and this degree. I want to thank my participants. I am a proud first generation college student, and this hasn't been done before in my family. And I'm really thankful that I've been blessed to lead the way for my sister. My family has only been able to see me present once, and that was in 2019. And so this is really big for myself and for them. And so just wanted to make space for them. My parents, who even at my big age continue to support me and love me and support me as if I'm still their baby graduating from pre-K, and my friends for loving me even when I couldn't show up as my full self. I want to thank Adrian. There's absolutely no way that I could have made it throughout this program without a community. I gained a brother, I gained a godson, and for that, I'm forever grateful. I have a lot of mentors and mentees who are present today. Um, if you know me, you know that I will forever scream Aggie Pride. And so thank you to North Carolina A&T. I really grew as a professional at Texas A&M, just moving very far away from home for the first time. I learned so much about the field, of course, but also about myself and what it took to thrive in foreign territory. To the Bridge program at Duke, I interned at the Wake Forest School of Medicine with the Maya Angelou Center for Health Equity. I also wanted to pause and make space for my work colleagues, both former and current. Wanted to pause and thank my community for serving as for serving in that role. Want to thank Dr. Thomas for serving as my chair. And I didn't want to steal his thunder, but I am Dr. Thomas's first advisee that he's been able to chair. And so that has been a pleasure to work alongside him, and he has done this with grace and poise. Even this week during he has an engagement. I'm sorry, his wedding is this weekend, and so just wanted to pause and thank him alongside Dr. Appleton and Dr. Mays, who I've both had as professors in the program. And thank you both. And to Dr. Smallwood. Smallwood started as my chair and elevated into a new role at Wake Forest. And so just wanted to pause and thank him for his commitment and staying on my committee post, his employment at the university. And I just wanted to thank me for not giving up. And I'll pause here. Here are my references, and that is it for me. Dr. Thomas, I will yield back to you.
All right, thank you, Tyrone. Great job. And just to reiterate, Tyrone is my first student that I am chairing, and it's been an honor being his dissertation chair. Um, Been a great experience. Tyrone has worked very hard on this dissertation, and I just want to give him his flowers and recognition at this moment. So great job. So at this time, if anyone wants to say anything, mute themselves or turn on the camera, feel free to ask any questions at this moment.
Okay, I see two hands. I see Alexis.
Okay, I think I'm not sure if they're able to unmute themselves or not. Let's see. All right, so we'll go with
There we go. It should work now.
okay. All right.
Hi, Tyrone. I just wanted to hop on and say amazing job. I was trying to drop it in the chat, but your chat was locked, so I definitely could not log off without saying, one, congratulations. Excellent job. I learned a lot. I also like that you really highlighted um, from a different perspective, as well as even including like women, and how like it's really a community thing and it's not a silo. So congratulations and job well done.
Thank you, Dr. Berry. And I see Dr. McCroy.
Hey, Tyrone, I want to say congratulations to you, man. As a person from the hometown of Red Springs, North Carolina, this is for the masses. They always say nothing good comes out of Red Springs, but I have to speak truth today. You've done a phenomenal job with this work. I'm ecstatic for you. When you first mentioned about your journey, I was praying for you and hope all would be well. And it's so good to see you reach this milestone. And your information was robust. It was very timely, and it's not studied enough. So I look forward to see what happens in the future ahead. So thank you, Dr. Thomas, for allowing this young man to come and deliver in such a professional way. Again, congratulations.
Thank you, Dr. McCroy. And I also see Dr. Chanel.
Good morning. Congratulations, Tyrone, and a special thank you for amplifying such an important message. As a native North Carolinian and rural advocate, this is really important, and most of all, amplifying the voice of African American males. Thank you and congratulations.
Thank you, Dr. Chanel. And I see Erin.
Hi, good morning. I just want to say kudos, Tyrone, that we're on behalf of the whole ASTO team and your colleagues, just want to say congrats, Dr. Bethune. We are incredibly proud of you and behind you 100% of the way, and just really, really pleased and honored that we've been able to see your presentation, and just want to commend you for continuing your hard work in finishing the program, but also just showing up as your full self and taking all of this expertise and knowledge and incorporating it into your work on a daily basis. And the management of both, how you've been able to do that is beyond me. So kudos and congrats, and it's time to order some new business cards.
Thank you, Erin. And I see Ramaya.
Good morning and congratulations. I wanted to ask if during your research, did you find or experience anybody that could not answer your questions or did not know how to answer them, and how did you go about that?
A very good question. Yes, I had several, that happened several times. And so that's the beauty in using semi-structured interviews. And so I'm able to ask those follow-up questions and to make those questions more plainly, or, give them ideas for how to answer that question. And so I can't answer the question for them, but I can, lead them to ways that they can answer those questions. And it's not easy talking about health, particularly as a Black man. And so just opening that space and creating space that was a space that was safe for them to share, I think really allowed them to reframe and rethink how they could answer that question when it was a difficult question. That's a good question, Maya.
Thank you and congratulations.
All right. Do we have any more comments? I know you're getting a lot in the chat. Adrian.
Dr. Thomas, hey, I just want to thank Tyrone. You did an excellent job for being unapologetically you, and to also to esteem towards a study that is under-researched. As far as with African American men, is not only important for North Carolina, but for the entire United States. So Tyrone, thank you again. This was very robust, and like I said, I know I helped far as with the interreliability per se, but good job, man, and congrats, Dr. Bethune.
Good morning and congratulations. My question is, where do you see yourself going from this point? Do you have anything planned from this point?
That is a really good question. I think that my gifts will make room for me. I don't know where I'm headed, but I am blessed to have a really, probably one of the best jobs I've ever had right now. And so if that's growing in place, if that is going somewhere differently, I think that growth is at no surprise to someone who's graduating. And so I don't know, to really put that plainly, but I am, really looking forward to growing. And so using this as a way to really catapult my career and to see where it leads me. Thanks, Naya. And Simone.
Good morning to members of the committee, his coworkers, family, and other friends. I just wanted to share, Tyrone, that I am so very proud of you, to know you as a friend, as a faith partner, as a researcher, and so much more. I'm grateful for the research that you did to, again, as others have shared, amplify an issue that affects the Black community, but most specifically Black men, which I know because you can relate to that is so near and dear to you. So I am so very proud of you. Congratulations. And God be with you as you enter this next stage of your career as Dr. Tyrone Bethune.
Thank you, Simone.
You're welcome.
All right. Does anyone else have any comments or questions?
I just wanted to say great job, Tyrone, and congratulations.
Thank you, Sean. Thank you, Sean. Appreciate it. Thanks for joining.
Good morning. This is Adrienne Wallace, all the way from College Park, Maryland. I am so proud of Dr. Tyrone Bethune. What a presentation that you've shared with us today. And I wish you the best of luck in what is next to come, which I know will be big. You have certainly set the standard for yourself, but for your family members and others to come. So great job. Well done.
Thank you, Adrienne.
All right. Well, it looks like we have concluded the question and commenting portion of the dissertation event. I'd just like to thank everybody for attending. Thank you all for taking time out of your busy schedules to see Tyrone's work and his research. At this time, I would like to ask everyone who accept the dissertation committee to please sign off of the Zoom. Thank you for attending once again. And thank you for your support to Tyrone.
Thank you, everyone.